Hi, everyone. Welcome. Good evening. My name is Seth Lewis, and on behalf of the Harvard University Division of Science, the Harvard Library, and the Harvard Bookstore, it's my pleasure to welcome you to the latest installment in our Science Book Talk series. I'm thrilled to introduce tonight's event with Joshua Weitz, who's presenting his book Asymptomatic, The Silent Spread of COVID-19 and the Future of Pandemics. Before we dive into the book, a few updates on the series. We have 2 more events this month. On March 26th, Kelsey Johnson joins us to discuss her book, Into the Unknown, The Quest to Understand the Mysteries of the Cosmos. And the following night, March 27th, Athena Actipis presents her book, A Field Guide to the Apocalypse, a mostly serious guide to surviving our wild times. For more information and to stay up to date on all things Harvard Science Book Talks, make sure to subscribe to our newsletter, follow us on, I guess it's X now, and check out our YouTube channel for the latest videos. The event tonight will he'll have about 15 minutes presentation and then followed by conversation, and then we'll have time for audience questions. At that time, if you raise your hand, someone will come around with a microphone. And then lastly, when the event concludes, we will make our way over to the Cabot Library for a small reception and book signing. Now it's my pleasure to introduce the speakers. Joshua Weitz is a professor of biology at the University of Maryland, College Park, where he holds the Clark Leadership Chair in Data Analytics and is a faculty member of the Institute for Health Computing. Previously, he held the Tom and Mary Patton Chair at Georgia Tech, where he founded the graduate program in quantitative biosciences. Weitz received his PhD in physics from MIT in 2003 and did postdoctoral training in ecology and evolutionary biology at Princeton from 2003 to 2006. Weitz directs an interdisciplinary group focusing on understanding how viruses transform human and environmental health. Weitz is the author of multiple textbooks on quantitative modeling of living systems and is a fellow of the American Association for the Advancement of Science, a fellow of the American Academy of Microbiology, and a Simmons Foundation investigator in theoretical physics of living systems. Joining him in conversation tonight is Bill Hanage. Hanage.
Rhymes with marriage.
Hanage.
I'm not fancy.
Okay. Hanage. Gotcha. So Bill Hanage is a professor of epidemiology and associate director of the Center for Communicable Disease Dynamics at Harvard T.H. Chan School of Public Health. His research and teaching focus on the epidemiology of infectious disease and the evolution of infectious agents. He received his PhD from Imperial College London. Dr. Hanage's work has studied many different microbes, both bacteria and viruses, and he is especially interested in how infectious threats evolve in response to interventions such as vaccination or antimicrobials. His awards include the Fleming Prize from the Microbiology Society and a Young Investigator Award from the American Society for Microbiology. We have a lot to learn tonight, so without further ado, it's my pleasure to turn the stage over to our speakers. The floor is theirs.
Thank you very much. I assume that's working, and I'm just going to speak loud enough in the back. Thank you for coming, and again, thanks for all the folks at Harvard Bookstore who made this possible. I'm going to start with something a little bit different, just to remind people what we do in science, because I think there's some confusion these days. And with some nod to Rumsfeld, I've drawn a little map here. It's not quite to scale. There's more unknown than there is known. But you see above, there's a known section and unknown, and I think maybe there'll be a few students here. Let's see if I can get the clicker to work. There we go. Answerable, your homework, things that we assign, we know the answers to, and you might ask why we're asking the students that, but we think that if they figure some of that out, they might be able to go off there, to the upper right, these really hard problems that aren't yet answerable. I think part of our job as scientists is to sit somewhere at this interface, right? To try to pose problems at the boundary between the known and the unknown, leveraging the things that we do know to try to move this boundary forward, right? So we're trying to identify, it's really hard to jump out there and solve the climate crisis and figure out new particles in the universe, but maybe with time we can advance this boundary. This is what we do. And this applies to the world of infectious disease. It's not always fast, but it's definitely different than how it's been done in the past. This is more than 200 years ago. This painting, some of you may be familiar with it, depicts what is considered the first vaccination, where Edward Jenner inoculated this young James Phipps with an active lesion from a milkmaid at the time who were widely understood not to get smallpox, Sarah Nelms, and then James Phipps ended up getting fever, recovered 9 days later. This is May 1796. And in July 1796, Edward Jenner then took an active smallpox lesion and infected James Phipps. James Phipps survived. In early 2020, and by the way, that would not have passed IRB protocol, clearly. So we know that to be true. Early 2020, very soon after SARS-CoV-2 was identified and sequenced, already groups, including those at NIH, were working together to identify the spike protein, had the right features. Within a year, less than a year, we have a highly effective mRNA-based vaccine, which you can see here, days after dose 1, cumulative incidence in the placebo versus the vaccine arm, and within a week, 2 weeks later, you can see the divergence, and there's greater than 90%, 95% above improvement with respect to symptomatic infection. Right? So the point I was trying to make here is not just that science, people say the arc of justice, it bends, the arc of history bends towards justice or forward somehow. This is not passive. It is not happening on its own. It takes scientists, right? Scientists who work together to try to move this forward. But the problem with pushing this boundary is that the unknown and the new can elicit fear and distrust, stoked by misinformation. And so as we're doing this, at the same time we're trying to push this boundary forward, there are people who quite effectively are communicating things that have nothing to do with evidence and data and the scientific method, but they certainly have consequences. Whether it's this false link between vaccines and autism, or people actively trying to ascribe deaths of measles to the vaccines, or other fake or junk cures. And so I think what this means for us as scientists, but also in the public at large, is that we can't just be doing science. We also have to focus on communicating that rigorous science in accessible ways. And I think ever more so, it's essential to scale up what it is we do discover to advance environmental human health. This is a small bite at this apple. It's what I've tried to do. I've tried to communicate what I think, and I think what others might share concerns with, that diseases like SARS-CoV-2 that can transmit even in the absence of infections pose significant global harm. And that's really the central message here. I'm going to give it away here at the start, giving you the bottom line up front. Diseases that can transmit silently may cause less harm to individuals. You may be less worried about it as one individual, but can lead to far more fatalities in populations. And if, we'll see how far Bill and I get tonight to explain this and how far you dive into the book, if you buy that premise, then that means we should do something about it. But in order to do something about it, we have to confront not just the individual who feels really bad and may be severely ill or hospitalized. And yes, we need to treat all those individuals, but we want to have fewer of those individuals. And the way to do that is to try to stop transmission even when individuals feel fine. Now, I can't go back all in time and relitigate or recapitulate what has been a long 5 years, and I'm not going to do that in the time I have before we go into dialogue. I will note that it's an auspicious day to have this conversation. 5 years ago, this is when the WHO declared COVID-19 as a global pandemic. About a month later, this was the state of affairs in the United States. The x-axis, time, year 2020. The y-axis, deaths per day. On April 13th, thereabouts, it's about 2,000 deaths per day. As folks know, it got up to 4,000 deaths per day later in that year. It was at this moment that people began to question what was going to happen next. And this is a lot of what we do in modeling. We try to take systems where we're missed information, and we're trying to project forward, maybe not too far forward, but certainly forward in time to help advise both hospitals to prepare, but also the public to understand what might happen. And as it turned out at the time, perhaps the most influential model coming out of the Institute for Health Metrics and Evaluation It's an independent research group associated with the University of Washington, made the following prediction. And what you can see there is the solid line denotes the data, the dashed line denotes the median prediction, and the shades denote the uncertainty. And there are some young and more mature students in this audience, and you might wonder, when you make predictions, you tend not to be so certain about the future. The greatest uncertainty was on the day they made the prediction. And then the uncertainty goes away. An influential model predicts deaths will stop this summer. Experts, including Bill, who had a very pithy, excellent quote, I think along the lines, not sure how that's possible. And I think one of your former colleagues say, I think the model's rubbish. I think that was more or less what that other person said. That was, yes?
What was the uncertainty based on?
I'm explaining in a second. It's a half slide away. I haven't even gotten through the slide. No, it's great. Part of the uncertainty is this was not a model of the kind that we'll talk about today that tries to imagine how many individuals might be susceptible, infectious, or recovered, or at different stages of infection. But it was something what we would call colloquially a curve fit. And because the curve fit was a curve that always goes down, then you guarantee that soon it will go down. You're not quite sure of the date. And in fact, the model kept fitting and predicting it would go away. It just kept pushing back as the model was wrong. But you're not sure quite where you are in the curve, which is why there's all that uncertainty. Now, it turns out what this was a recapitulation of something called Farr's law. William Farr, not Farr's fault. He was doing great work in the 19th century on smallpox, noticing that smallpox epidemics would go up and down in a seemingly symmetrical-like fashion. And if things go symmetrically, we should be looking for slight inflection points. So they were looking for these inflection points and saying it would go away. The issue, of course, is we know a lot more now. We're aware of what's going on, at least in part, with fatalities, and people can change their behavior, either because they made the choice to change behavior or government, states, ended up, and obviously in regions throughout the world, ended up having these stay-at-home orders. The result was not a single peak in disappearance. The vast majority of us remained immunologically naive and therefore susceptible, and therefore when behaviors changed, spending more time indoors, taking off masks, or again going back to normal social interactions, then once again we saw peaks and peaks, in other words, waves and waves. There was another pernicious component to all this. People felt fine, but were nonetheless able to infect others. This is an example of a high-speed video still taken from Lydia Bariba's lab down Mass Ave at MIT. She induced herself to sneeze, so you see her in the upper left. And what you can see here is a puff of air containing a spectrum of sizes of droplets that could potentially travel much longer than 3 to 6 feet and linger in the air, not ballistically like a ping pong ball falling to the ground. We also knew some of this was happening very early on. I'll give just one example. This is from a restaurant in Guangzhou, which is south of Wuhan, January 24th. The focal individual, A1, different family units came to this lunch, sat at different tables, were told to do so because of the threat of SARS-CoV-2. And A1, it turned out, was pre-symptomatic. In other words, had no symptoms, but was infectious. All the individuals who were circled became infected during that lunch. With contact tracing, you can see the distances, the room is 20 feet across, far longer than 3 to 6 feet. There's even worse example, and if you were here for Carl Zimmer's talk, the Skagit Valley Chorale, in which a single chorus practice ended up leading to 53 infections, even though no one shook hands and was supposed to be practicing social distancing, including 2 fatalities from a single event. And there's one additional piece of the puzzle that we knew early on. And again, I'm trying to make this point that this asymptomatic, potentially airborne transmission was a key part of what made SARS-CoV-2 hard to stop. There's a concept, it's somewhat difficult, but this is a science book talk series, so I want to explain the idea. The idea is one of a serial interval. Serial in the sense of a sequence. It is the time between when the infector exhibits symptoms and the person they infect exhibits symptoms. So you can imagine, I'm going to pick on Bill here, that I showed up, which I wouldn't have done, but let's say I showed up symptomatic to this event. I interact with Bill. I haven't seen him quite some time. No one else is feeling ill. And my symptoms had appeared 3 days ago. He gets sick and his symptoms show up a week from now. Therefore, there's a 10-day difference between when my symptoms showed up and when his showed up. We have a value of 10. And that's typical. Long numbers, because first we imagine we get symptoms and then we infect others. They incubate the disease, they exhibit symptoms. You'll notice something here quite striking, which we knew in early spring 2020. 20 to 25% of the serial intervals between infector-infectee pairs, which they know because they could work out where people were coming from, were 0 or negative. Which means we show up to this event, I don't have symptoms, but I came from Wuhan, Bill's in Guangzhou. There's no SARS-CoV-2 in Guangzhou. Thursday, he has symptoms. I have symptoms a week after him. So now we have a negative serial interval. There's no way for us to go and do contact tracing and try to sort things out. Even before I have symptoms, I'm infecting other people. What does this mean? Asymptomatic transmission and infections are often good news for individuals. The risk that you as an individual may have a bad outcome goes down the higher the prevalence of these asymptomatic outcomes, which is you see in this red curve. But the number of infections go up because individuals interact with others, they feel fine, and you can understand that the population outcome is somewhat of a product of those two curves. And you start to see the ends are not really often what we should be worried about. If there are no bad outcomes, for the most part like common cold, or even things like Ebola, which is terrible, but doesn't maybe cause as many new infections. It's the stuff in the middle. And I want to wrap up before we switch over to talk and dialogue with just 3 simple examples. SARS-1, 2003 through 4, on average, each individual was infected would cause 2 to 3 new infections. It was a bad disease to have as an individual, 10% fatality rate, yet nonetheless only around 800 total fatalities. And conventional public health measures like quarantine, contact tracing, mask wearing was able to quash it. Ebola, which we worked on in terms of safe burials, awful disease for individuals, 50% fatality rate for those who have it, less transmissible, something between 1.5 or so to 2.5, depending on context, and yet on the order of 11,000 total fatalities in this largest outbreak. SARS-CoV-2, COVID-19, at the start, before people were aware of what was going on average caused 3 secondary infections per infected individual, not that much larger a number than the other 2, and had a much lower fatality rate. Yes, it depends on populations and it varies, but something on the order of 0.5 to 1%. There are 7+ million documented fatalities with respect to SARS-CoV-2, and excess mortality estimates put the number in excess of 20 million. And it's this combination, as Anthony Fauci said, a disease that half the time causes basically no symptoms, but sometimes is severe enough to kill you, that combination is really at the population scale, which makes it so dangerous. I want to close with an image from a book some of you may be familiar with. This is images from the Black Death, Lord have mercy on London. And at some point during the pandemic, I tried to read Daniel Defoe's A Journal of the Plague Year. I didn't get all the way through. It gets a little repetitive. But there was one section which I want to draw your attention to. It has relevance. Here also I ought to leave a farther remark for the use of posterity concerning the manner of peoples infecting one another. Namely, that it was not the sick people only from whom the plague was immediately received by others that were sound, but, and he capitalizes, the well. These were the dangerous people. These were the people of whom the well people ought to have been afraid, but then it was impossible to know them. It's describing many of the things, right, that we faced at the start, with one difference. It is time to confront the impossible. We can, in fact, know who may be infected even in the absence of symptoms. Whether we do And how much of that we do and to what ends remains open. With that, I just want to say one last comment, especially to link to the start. I wrote this book in a period, 2022 to 2024, but the work that we do is that of a group of collaborators, of a collective effort. And I just want to highlight, especially now, that all of the work that we've done has been made possible by a global team of researchers. And at present, even we have folks from the US, UK, Germany, France, Italy, Belgium, Mexico, India, Singapore, and China, and I'm proud of them. I'm looking forward to talking more with Bill and then with you. Thank you.
Thank you very much, Josh. Do you want to come round and?
Yes, this is transcribing, which may be helpful for some people, but it is transcribing.
Cool. Let's see how it's.
And I stopped sharing. Was I supposed to share the screen? Okay. So that's going on.
We can check out how it transcribes my name.
Okay.
So, hi, everyone. Thank you so much for coming. Thanks to the Harvard Bookstore for helping to, for making this happen. Because I think it's it's a really great opportunity. And also, since you wrote the book, a few things have changed in the world.
Really?
Yeah, one or two. So, and it makes it remain extremely relevant, shall we say. But before we get into any of that, one thing I wanted to, from a scientific point of view, because as you said, this is scientific. I think if there was one thing that I could figure out, one thing I could name that is the difference between the way people like you and me think and people who are lab virologists think, is that we do not ask only whether something can happen, but whether it happens enough that it is important. So in this case, asymptomatic transmission can happen, but it's the proportion of it that is pre-symptomatic or asymptomatic that matters. And that's a hard thing to estimate. So I just wanted to give you the chance to respond and think about that.
Yeah, so at the very start, I mean, these are questions of how should we spend our time? Right? We're confronted with this novel coronavirus. Our group is a viral dynamics group. And we asked ourselves, and I asked the group as well, like, if we don't step up into the fray here, if we don't try to engage, then what are we really doing, right? It can't just be a question of theory. But then as things and data started to come out of Wuhan, one of the first things that happened was someone from the CDC brought to our attention that this asymptomatic route was being identified and felt that it was not just, as you say, a possibility, but it was relevant. And there's a huge difference there because we also learned this with Ebola, that there's a potential for Ebola of post-burial transmission. So people are dead, but they're still, in fact, some of the largest transmission events happen with burial practices. And it's not uncommon for people to touch or get close to individuals who are dead during sacred rites. And so part of, and this happens in all cultures, right? All cultures. So part of the effort there was to say, well, is this something that is occasional, or is this actually driving super spreading events? For asymptomaticity, the key events, I think, happened very early that we already knew. There was the potential for an individual, especially if they were unaware, to infect many people. And in the end, it's one of those things that with time, I think, unfortunately, got validated, that the frequency of being asymptomatic was on the order for populations about 40 to 50%, about half of the infections. And even those who had symptoms could transmit in the period where they didn't. So there was pre-symptomatic transmission. So for better or for worse, this was an area that I realized with time was just going to have to be one of our central preoccupations.
I couldn't agree more. And speaking personally, I mean, I remember in February 2020, I happened to be in Tel Aviv, and I was able to go into the isolation unit, which had been set up there for people who had returned from the Diamond Princess. And the CT scans, they had a CT scan in the isolation unit. It was amazing. The CT scans showed ground glass opacity, which was consistent with the pathological process, but the symptoms were minuscule. They were tiny. I think one person spiked a fever, and they were couples, so they were reasonably expected to have transmitted to one another, which indicated that in this group of people, there were about 10 or more, there was there was a pathological process, surely with the potential for transmission, and yet symptoms had not been documented. And this is the same virus that had caused a huge spike of infections and crisis for healthcare in Wuhan. So that was for me at the end of February. But Mike Warraby since has actually found that this was a finding that was also documented by Chinese doctors towards the end of December. So that was known earlier than that, and it was extremely evident.
Yeah. So, and we'll kind of get into some of these lines of evidence, but there were multiple lines of independent evidence of the potential for asymptomatic and post-asymptomatic and pre-symptomatic transmission to be relevant. And I don't know.
I was going to jump in on that because one of the things which I remember at the time, I'm so glad that you mentioned those, because I don't know if you remember the introduction to Germany where people said, oh no, it's not asymptomatic transmission because the person had taken Tylenol because they had a headache. But that's a false distinction, I think, as far as I'm concerned.
Yeah,
I think you'd agree.
So, right. So there's both. Okay, let's step back for a second. We come to disease as individuals, and then public health professionals have to come in with paradigms. And so I think there were a number of paradigms where this diverged from intentional playbooks that were geared more to flu, for example. And even though flu does have post-symptomatic transmission, at least for the case of SARS-CoV-2, between the Diamond Princess, this very kind of unfortunate story of a ship, the cruise ship, with again older individuals leaving Japan that couldn't come back into port, or this coral visit in Washington before people realized what the potential was, or this restaurant example, or many others, in which you can see, you can come up with particular explanations. Maybe it was the air conditioner, maybe it was older individuals, maybe there's something about singing. You have to come up with yet another exceptional explanation, except there's a simpler explanation, which turned out to be true. And again, we can get into the other issue, is that if we had larger testing capabilities, then we would have been able to show at scale earlier in the US, despite what people said, that people were infected using kind of these standard PCR approaches, which now we all know about, right? That you go and get the nose swab and they tell you whether or not you're infected, even without getting symptoms, right? And so there's many ways in which those in a narrower group were very worried for the reasons I explained here. But it seems to go counter to your intuition that first you have symptoms, and that is the point. And therefore you can make a good personal choice, right? You can make a choice that's good for you and for other people. But if we don't have that information, then we're not even able as individuals to make the choice. And that's obviously something that we tried to address later, but we'll get there.
Yeah,
I think.
I think we will.
Okay,
yes, but
good.
I mean,
We'll see.
the additional thing here is like, obviously, if your criteria for testing include that you must have symptoms, you are unable to detect asymptomatic or minimally symptomatic transmission. And you're unable to detect, this is especially true for a virus like this. I wanted to ask you how this has moved your sort of personal calculus when you think about a potential emerging infection. Because when we hear about it, you'll often hear folks say, oh, but it's very mild. Or, oh, but it's no evidence that it has a very high mortality rate and stuff like that. I mean, I would argue that that's exactly what you need to be worried about.
Yeah, so there are notions within epidemic dynamics, studies of epidemics, they have a couple key numbers involved. And I think probably people remember this notion of R naught. You heard about it in the papers, and the number of new infections caused by a single infectious individual in this otherwise susceptible population. We refer to it colloquially as the strength. How strong is the disease with respect to transmission? And there's also the outcome, which is this infection fatality rate, which also is tricky because we don't measure it, actually. We measure this case fatality rate. We have documented fatalities, and we divide that by documented cases, right? And if we're missing a lot of infections, then maybe the true infection fatality rate is much lower. But I would argue that there's another feature, and it's the reason why I showed that histogram. I can do this at Harvard, right? I can show you the histogram here, because I want to make the point that this serial interval, the gap between when someone can recognize their symptomicity and the time that someone else has symptoms is a crucial feature of controllability. And we tend to think of that number as big. But yet for many diseases, there's been some nice reviews, things like polio. The vast majority of people exhibit no symptoms, but can transmit. Obviously, that's not something yet we're thinking about here in the US. But there are example, I said the word yet. There are example after example, again, even measles. We think of the characteristic rash. Maybe you have a fever. Transmission of measles is possible, and this is on every WHO, CDC website, 4 days before someone has a rash, and they're probably even beyond that. So what that tells you is that you may not necessarily know specifically, or you'll have no symptoms and still transmit to others. And that number, some of the things that I think we should be doing, is doing a better job of really understanding the balance between infection outcomes that are symptomatic versus asymptomatic, and also the timing. And to wrap up this answer, and I'm not keeping it short, but I'll try, the last part of this answer is simply that to do that, we need to invest in the very things that we're not quite investing in now, which is contact tracing and really detailed epidemic investigation, because we need to learn this early. Right? We need to learn.
I think we may well be coming to that with some of the questions from the audience.
Yeah.
But before then, there are a couple of things that I jotted down in my copy that I wanted to bring up with you because I was especially impressed by them. You mentioned miscommunication in your introduction. By the way, I'd point out we may have an expanding field of knowledge. That means we also have an expanding perimeter of ignorance, unfortunately. But with that in mind, could you say something? You mentioned experiential bubbles in the book. And I thought that was a really compelling chapter, and I thought it's extremely important to pandemic management. And I wondered if you wanted to say a little more about that and about the role of misinformation in experiential bubbles.
Okay, so the word that was just used is experiential bubbles. You have to get somewhere deep into the book to hear.
That sounds quite fancy.
Yeah,
experiential bubbles, but this is Harvard. We can do histograms,
No, but-
we can do experiential bubbles.
But what I meant by it and what I've tried to communicate, and this was me in two senses of a bubble. I was working in Georgia during the pandemic. I can assure you when I would communicate with people in the Northeast, including here in Boston, that our experiences were different, very rapidly diverged. We had some ideas of what we thought the state should do, and we ended up communicating with certain members of kind of standing committees that were going to try to communicate best practices. And then we would learn maybe a week later that the governor made a decision that we were all going to open up because the data showed that it was time to open up. And what that really meant was that we were getting case reports, and on any given day, they lag because you ascribe them to the day of the test. So it always looked like it was going down, and if you wait 4 days later, then it just went back to where it was. So even within a state, we had a very different idea of what was going on. But the point that I was trying to refer to in the book is that for young people versus middle-aged adults, like myself, older individuals for whom the risk was higher, these were really different outcomes. And I think it was hard at the start to communicate. There was some uncertainty. But we also had data early on that said there was a strong age-dependent risk of severe outcomes, hospitalizations, and fatalities. And if that's true, it's sometimes hard to kind of grapple with it. We were going to be better off trying to communicate, in my view, sitting, for example, at a college that reopened with people back in the dorms in August 2020, that we were trying to have people take protective measures so that they would not infect an older individual. If they got infected, they were probably going to be okay. Not great, but they were probably going to be okay. Right? And that is something I think we have to say when we know it, because that honest communication, if we tell them there's a real chance that you might die as a 20-year-old, and they know dozens of people, because in some cases we had entire fraternity houses, almost everyone getting infected because of the way that if it gets into one fraternity house, everyone's going to get. These are not meant to isolate. Then they know that that's not true. And yet for individuals who were in long-term care facilities, this is a real risk. And as a population as a whole, it's a real risk, right? There was, I think, something in New York City, state of New York, 20,000 fatalities in April 2020, 1 month, right? That's a national level of flu fatalities in one location in 1 month. So this was the difficult thing to navigate. And as we moved ahead, the book tries to explain ways of being frank, both about ways that this is dangerous to populations as a whole, but it also diverges in some risks, for better or for worse, and that, frankly, makes it harder to control too.
That's a great comparison. I mean, thinking of my own experiential bubbles, how many people here work in healthcare or anything connected to healthcare? Quite a few. So, I mean, my experience was one in which I was having calls with people where they were saying, we ran out of nurses, the ICU's full, we don't know, we have to do this. I have a friend who's an OBGYN who had just come back from a pretty major surgery, who had to work in the ICU because there weren't any doctors who hadn't, they were just all sick. I mean, this is, and then when you put it into that context, 20,000 deaths, a national flu mortality over a year in one city.
I have to be careful whether it's state or city. I believe it might have been state.
It was mostly
city, right?
It was mostly the city because those were overwhelmingly concentrated in New York City. And yet so many people have forgotten.
So there's my intention in some sense, and maybe that was a question, but I'll take the question. With respect to fog, right? This is a long 5 years. And in some sense, I decided to write this book to try to present what I view as a synthesis of some of the key lessons I think we can learn, both for better or for worse about responses, but also identify driving principles that I think made COVID as bad as it was, but also present opportunities for some of the successes we did have, although they were limited, that we could then apply in the future. Right? It is really hard to go back in time given stress, and you sort of misascribe events. I mean, there's classic studies when there's a traffic accident, no one can remember exactly causality, what happened before what. And you extend that over a multi-year period where people are worried about their lives, about their loved ones, about their financial well-being. So I wrote this in 2022, at least the start of it, early, at a period after 2 straight years of sort of intensive work where I felt that I couldn't just keep riding the wave of responding to reports, coming up with a new model. I was also starting to lose track of what the big picture questions were. So I'd like to think, this is an effort to break through some of that fog and highlight, it's not the only thing to highlight. I have my field of expertise, but I think there's this notion of asymptomaticity is one that we need to add as just important as the strength of the disease, the fatality risk, and in fact, if we want to control things, knowing this and thinking about how we characterize it early is something that we can take away.
Yeah, and I agree thoroughly. I wanted to come back to something which I think you may have alluded to earlier, which is different testing modalities and how they might be helpful in dealing with infections of this nature in future.
Yeah, so the last slide I had is it's time to confront the impossible, which in 2020, I mean, if you think about the number of, there were a couple miracles there that were positive. 1 year from identification of this novel virus that was causing a global pandemic to the availability of vaccines within a year and a half, billions of doses. Right? That's one. The idea that we could test individuals and within a day at the start with PCR, but soon, many of you know Michael Mina, who was your colleague, yep, right? For quite some time. Some of you might be familiar with that name. He and others promoted this idea of rapid testing, the idea that one could, at the point of contact, do a rapid test and know within 15 minutes, not perfectly, some information specifically often about positives. I'm very worried, getting at least some notion of specificity. So you get sensitivity, so you know when someone actually is infectious. To be able to do that allows us to separate out symptoms from infectiousness. And the advantage there becomes if we do this often enough or early enough, we can make a real dent in transmission. So in May 2020, then President Trump, first time in office, was in Allentown, Pennsylvania, and he was very annoyed by all the testing. So the more we test, the more cases we find. If we didn't test so much, we wouldn't have so many cases. Now, no,
Not wrong.
well, it's right. It's not wrong in some sense. No one would argue that for HIV/AIDS, right? No one would argue that not knowing is a good thing, right? Knowing means treatment, right? Early treatment, and stopping transmission. No one would argue, and there are balances there with too early screening of cancer, but certainly knowing something about a disease often helps, typically helps, not just treat the individual, but then for infectious diseases, stop transmission.
And stopping I mean, just not to get too quantitative about this, but you put up the reproductive number. If the reproductive number is 2, if everybody infects on average 2 other people, you just need to stop half of the onward transmission events to have brought it under control and put the reproductive number below 1.
And so that's exactly what we ended up deciding to do in practice, and many universities did this. So Harvard did this, University of Illinois Urbana-Champaign did it, UC San Diego. We did it at Georgia Tech at the time when I was there. We don't have a med school, we don't have a public health school. We have engineers, and we had a few of us who tried to make the argument that if we could launch an asymptomatic testing campaign, we could end up doing precisely what you just described. At the time, the R0 was lower, maybe it was 1.5, but that means we even have a greater chance. If we can just find, it's easier, right? So if we're already doing some of the steps, we don't even have to test everyone. And in fact, we couldn't. So at the time, there was a mandate that said we could have no mandates. It was the anti-mandate mandate, meaning we were not allowed by the governor to impose tests on individuals in order to be on the campus. It all had to be voluntary. But again, we were already doing a number of the steps with respect to air filtering, people wearing masks in indoor spaces, which we did get that to be passed at least for 1 semester before it was banned. And we ended up doing something on the order of 2,000 tests potentially per day. And we ended up doing, in total, 500,000 free tests, greater than 500,000 free tests, particularly in the period of fall 2020 through spring 2021, as this gateway towards vaccines. And the whole rationale at the start is we made the pitch, and the president, EVPR of Georgia Tech were quite supportive, was that we felt we could stop large outbreaks from happening. And if we tested, we would at least know where they were, because there tended to be clusters. And if we knew where they were, we'd have a better job of stopping them from getting elsewhere. And that's what happened. Greater than 50% of the tests identified, of the cases identified on the campus were through this asymptomatic testing campaign. This is also going back to bubbles. Individuals in their late teens, 20s were more likely to have polysymptomatic or asymptomatic infections. So they were going to interact more and potentially even infect others. And this became then a strategy for us to say, before you go home for Thanksgiving, right, before you go to an intergenerational Christmas meal, can you please get tested X number of days before? Tends to be a good idea. And so our messaging really was about that kind of empathetic view rather than a scare tactic view. Now, where we stand moving forward, there's not the capacity nor the money to have everyone test at this kind of scale every few days. But there certainly is the capacity and the funds to use this selectively in vulnerable populations, or to have it available for those who are immunocompromised or have vulnerabilities. Long-term care facilities, nursing homes, in which there was a strongly disproportionate number of fatalities given the number of infections. So I think these notion from May 2020 really had it on its head. It was backwards. The more we test, the more infections we find, and therefore the fewer infections we get in the long term. So I really think we're at a point where we know this to be true. We've shown it. The question is, what is our willingness to do it at scale and appropriately?
So with that, I was thinking that I might ask my last question and make it asking you to expand on your chapter about vaccination, but I'm also reasonably sure that somebody in the audience will ask about that. So I was thinking I'm going to throw questions out to you guys now. There is a microphone. Don't be shy.
So both my PhD advisor, who's holding the mic, is passing it to one of my PhD mentors, and I don't know what's going to happen next.
This is your thesis defense.
Right, this is something is happening.
So we've come down to the essence of what your book is about, which is
have to hold.
We've come down to the essence of what your book is about, which is testing.
It's one of
Now,
the things.
Well, it's the essence, because in some basic sense, it's trying to pick out the asymptomatic people from the rest and be able to deal with them, because that is the heart of the problem of spreading the disease.
So I will say that if you go further into the book, and Hyman, you did say that it had to be interesting before you bought it. So I hope it's going to be interesting enough. But there are 3 parts to it. There are 3 parts.
I want to do the second part.
So let me tell you the other parts we didn't
The
get to.
second part
Wait, no, I'm
is-
going to answer the question first, Hyman, and then you're going to then ask the second part. The testing is one part, and don't worry, Hyman and I have been having an ongoing conversation for years, and my first book on viral ecology is in part dedicated to you, as you know. Testing is one part. Another key feature is thinking about what vaccines do. Vaccines were described, I think, were misunderstood as stopping all infections. And so therefore, when people had a breakthrough infection, they said that it doesn't work. The data that I showed you here was against symptomatic infections. The whole point was to stop symptoms and severe outcomes. That means that if at a certain point we got to a world where so many people, and again, durability is one thing, but we got to a point where people were vaccinated and what they had was a paucisymptomatic, asymptomatic, or mild infection, then I think we would have won. So it's very important to think about this asymptomaticity. It's the middle part of the curve that hurts. When there's a mix of some people with severe outcomes, some people with asymptomatic, if we got to the point where this was the common cold, because we were all vaccinated and unfortunately with hybrid immunity as well, that would be a good outcome. And there's a third, which is data and information. When there's not enough tests, because I agree tests are important, but when there's not enough tests, we still would like to have some notion of what is the risk, and this was one of the reasons we ended up building a tool, a dashboard that tried to communicate the risk that one or more individuals might be infected in a group of a different size in a county near you, and we launched it in July 2020. We ended up having more than 16 million visitors come to the site, and we delivered over a multi-year period 60 million risk estimates, and it was on day and night, which meant a lot of work, both communicating it, keeping the website up, because this was all a pro bono effort, but the whole point of it was that you could go where you were, in the county where you were, and just look, with at least a sense of, even if you hadn't tested or the other people hadn't tested, was this a period, because there was a biogeography of it. There were places, depending on seasons, that had greater risk than others. So I think really those 3 points are ones that I think we need to take away. Testing in a targeted way, vaccination at scale, and obviously there's hesitancy, which we're not able to talk about anymore. And I'm not joking there. There's some issues with grants being cut off for people who are actively working on vaccine hesitancy, which is one of the reasons we have a measles epidemic right now. And the third part, which is information. So those 3 together, testing, vaccination, information, are really the ones I try to emphasize.
But I want to.
And then we're going to have to pass on. I think this gentleman here had it. So one more question.
I had 3 points, so
No, oh my goodness.
I only heard 2. The third point is, obviously, what is and who are asymptomatic? Is this a population that are young and don't live in old people's homes?
It is a spectrum. So let me, I
is
think,
that-
yeah.
And could you, yeah, thanks a lot. Could you just pass on
Yeah.
to the
So
next?
just in the interest of time, let me just try to answer that too, which is, in the book I describe these at a population scale. Younger people had a higher likelihood of being asymptomatic, but older individuals also could be asymptomatic. You could have someone who typically would have a much higher risk factor of a severe outcome, but would have a mild infection. So this was not something where you can just use your age as a proxy and let you know in advance what's going to happen. You couldn't do it.
Great presentation and great work. So just a question about kind of the modeling. So you talked about for the transmission coefficient or reproduction number or not, right? You talked about the serial interval the time between transmitter infectious and transmittee infected, right? And then the CFR, the case fatality rate, as a proxy, I guess, for mortality, which we don't really have as accurately. Isn't there also a need to think about the time between when a patient is infected and becomes symptomatic? You mentioned it in measles, but I'm just curious, across the variants and clades and so forth that emerged in COVID, whether we saw, quite a dispersion of time in that variable. And I guess the other thing would be in the case fatality rate, if we get up to the levels of MERS or something like that, 30%, then people said, oh, this is one of the reasons why SARS-CoV-2 is so deadly, because it doesn't have such a high CFR that you sort of burn through your timber, right? Just so many people die so quickly and so forth.
So there are a couple of questions embedded in there, and I think some of them are in the active research discussion space. But this notion of intervals is important, and there are many kinds of intervals. The reason we talk about serial intervals, let me just move this up a little bit, that's a little better. The reason we talk about serial intervals is because we can't measure what we really want to know, in some sense, which are generation intervals, the time between when I'm infected and when the person who I infect gets infected. We don't know when that is typically, right? And so you're talking—
You can't ride on a virus into somebody else and then, and a stopwatch in order to figure out when that happens. You have to infer it.
But it turns out that, because of that uncertainty, that's actually one of the first things we worked on, because everyone had the same data in January 20. It was all the same data coming out of Wuhan, and different groups were making different assumptions about this unknowable thing. And depending on what assumption they made, they got very different outcomes for the strength. It could be by a factor of 2, which again tells you radically different outcomes, right? So that just kind of makes at least some point that things like, I think you're talking about like incubation period distributions, generation intervals, they're all very relevant, right? With respect to the last part, timing matters. So there are diseases for which ultimately can lead to fatal outcomes, but have long periods of chronic latency and can still infect, and in the absence of drugs would be fatal, HIV/AIDS, right? And so just because some disease has a higher mortality rate, depending on the time scale, doesn't necessarily mean that it comes at the cost, right? It doesn't mean yes, there's a symptomatic period, but it can be both. So this is, I think we're thinking about respiratory diseases or acute diseases. And in that case, to me, a lot of this has to do with the gap between let's call it the transmission intensity and symptom onset. And I took that, another long quote. I figured I had enough quotes in my short presentation, but one of them comes from 2004 from Anderson and colleagues who looked and tried to reassess, what lessons did we learn from SARS-1? And basically they said that the serial interval was positive, and sufficiently positive that we could do conventional public health measures. And they literally say we may not be lucky next time with an etiological agent. Now, you can't predict 20 years ahead what that was going to be, but they had some sense, I think anticipatory, that the controllability of it was related to that time. Yeah.
Classic paper. Steve Riley, Christopher Fraser, Neil Ferguson, Roy Anderson. Yes, sorry.
It's good.
It's
I remember the last author. You beat me on the other 3.
The second author was in the office next door to me at the time.
Okay,
so,
fine.
yeah.
You know them personally. I think we have 3, 1 in the back, and then also in the front here in the middle.
Yeah. If a new epidemic broke out and you were head of public health, how would you dedicate your assets?
Okay, this is a trick question because I'm definitely not going to be in charge of public health, and you haven't told me what disease it is.
You're not Robert Kennedy?
But, well, it's sort of like if we do the opposite of what RFK Jr. does, we might actually, I have a very bad sense of direction physically. So if you want to get to where you're going and I go left, you should go right. So I think that's kind of his style. Whatever he does, if you do the opposite, it might be the right thing. So with respect to what we should do, let's give some specific examples, right? We have 2 things going on right now in the country, more than that, but that I think aren't being handled so well. One of which is measles, and one of which is avian influenza. Is that, I don't know if that's fair.
I think it's fair.
Okay. And there are different things you might want to do with both of these. And just to give one example for measles, I think it's pretty clear that you should tell people that the best defense against measles is vaccination. And yet, that's not what's happening. Instead of saying that, there's a wishy-washy op-ed that almost gets walked back talking about nutrition. Healthy children can get infected with measles and die. And there are, I mean, some of the stories, the poignancy of some of these stories, and this is misinformation kills. I mean, is another way to think about this. And again, with respect to this asymptomaticity, we don't have the data right now. If you go to the CDC website, they are reporting cases once a week. Once a week. So we have a week gap before we find out what happened. We don't know how many people have it, and we're not doing testing. We are going to be less able, going back to the testing and the infections, less able to control it. For avian influenza, we talked about this before. There are farm workers who aren't sure how they got avian influenza, and they had avian influenza. Right? So
7%, I think, there was 7% of surveyed were seropositive.
Seropositive, right? So you have people who have unwittingly been infected. We're not sure. Now, we're not at the point where this is, we don't think there's significant human-to-human transmission, but certainly from zoonoses, where we're not sure are coming from, we have, again, an inability to confront a pandemic that is occurring within animals, livestock, et cetera. And again, part of there is testing. And you can test through wastewater, you can do extensive testing. So different strategies will be appropriate, but I think my key message would be simply that if we abdicate effective public health measures, we will get bad outcomes, point blank. And we can go deeper into it. But maybe we should take a few more questions.
And I would only add that even if you don't give a flying toss about public health, and you are only concerned about agriculture, more avian flu outbreaks is not going to do anything to bring down the price of eggs. Just leaving that there.
No, it's true. There's not. No. There was a question, I think, right here, and then if they still have an interest in the middle, but otherwise, right here. And maybe almost there. Hello.
Thanks. I appreciate it, especially you're saying scientists need to communicate more. It's not just this last few years, but certainly in climate and others. Scientists have not been involved enough. My question has been a lot of press recently, specifically about the COVID pandemic and how some of the science was wrong. There's a whole editorial in the Boston Globe, which I still respect, about, well, maybe there were some things that scientists did not acknowledge had not been working, and Dr. Fauci should have acknowledged some of that. Is that something you all are talking about and understand as one of the problems, or is that more misinformation of questioning, once again, scientists who actually are continuing to provide the best information possible, if that makes sense as a question?
I think so, and I think it's a complicated, the answer I will try to give, and maybe we both should reflect on this one and try to answer it, is that we certainly, and again, science and scientists, it's not a monolithic enterprise. We tend not to coordinate all the time, right? That's part of some of the fun and brilliance of science, that small groups doing their own independent thing often can reach conclusions that a top-down controlled group might not, right? So that's the good part. But that does mean there were divergent views. I'll just give a few examples of one. So in the book, I talk about airborne transmission. Despite the fact that this Gaggett Valley Corral happened early on, in late March 2020, the WHO had a very definitive statement that it took them over a year and 2 months to walk back, which was COVID-19 is not airborne. And what I think they meant, and eventually I began to kind of interpret WHO statements in my mind, is that we do not have definitive proof of aerosolized transmission of COVID below a certain size threshold. Anyone in the public hears that it's not airborne. Did it go through the air? Yes. And so when you say one thing so definitively, then people are going to be generally confused and not realize that it was going to be possible in indoor context, which is why we invested all this time in this sort of event gathering size risk estimator, that people might have a greater risk of being infected. So that was wrong, and I say so in the book. There was a mistake. And the people who tried, the aerobiologists, and if you were at Carl Zimmer's talk, it talks a lot about aerobiologists, that group, rather than the kind of the surface contact group, had it right. Science isn't going to get everything right at the start. It is changing. But what I see now is something different, in my view. The people who are saying everything, we got everything wrong, were some of the people from early on, including Bhattacharya, who was involved in something called the Santa Clara Serological Survey, in which they made a claim that COVID was perhaps 50 to 85 times less dangerous than everyone else had said because they found so many seropositives in the population. The only thing that could account for it was the fact that it was no worse or even less harmful than the flu. Now that to me, and then they doubled down, even as people explained not only was the study poorly designed, but just based on medical statistics, there was a chance the vast majority of their positives might have been false positives. We have to follow the data. The data doesn't follow our narrative. Then we stop doing science when we do that. And sometimes we'll get it wrong because we have preliminary data, but we have to correct. The absence of correction or self-reflection or ability to say by some of the people who are now in charge, to say, we got it wrong. You never hear them say it. It's always other people got it wrong, is deeply troubling. The head of an agency who's responsible for the direction of science, an elite institution like NIH, I would want to know they embody the values of the institution. And to me, one of the core values would be that the data tells us. There are beautiful theories. Theory can be beautiful, but the data tells us. So.
I think I'd just add that one of the ways you can tell a scientist is that what they say tomorrow is not perfectly predicted by what they say today because of the fact they've taken new evidence on board and updated. I think there's going to be a similar article in the Times coming up in a moment and in a while. I can think of a few things where I would love to have a do-over. I think schools could have been open for a much longer period with certainly with mitigation steps in place with relatively small effects. But we should not take from that the message that any future pandemic will be appropriate for any future pandemic. Because it could be that a future virus will spread more in schools and be more dangerous to children. So we should make sure that we don't learn the lessons of the last war.
Yeah. And maybe I'll just add there too, which is the whole second part of my book says there's more to pandemic response than lockdowns. And a lot of our emphasis were on ways that we could be more targeted in responding. And that also addresses potentially what I view as this false dichotomy between either we all get infected, right? We open everything up, or we lock everything down. This doesn't have to be a false dichotomy between socioeconomic well-being and health. I think there are a lot of ways that if we're smarter, use data, use testing, push vaccines to the point where we get population coverage, we can do a lot more and both be healthier and keep the economy going. I know we're getting close to time, and there was this gentleman in the middle. I don't know if he still has a question. Okay, and I don't know if you decide if we have a last question here before we wrap up, or we need to wrap up and go to the reception.
Let's go with one more. Or then you're going to have to fight about who's going to answer.
Okay, we'll answer quickly.
Okay, what's the current thinking on how effective masks are? In both ways, if someone has COVID and they're wearing an adequate mask, and if I don't have COVID but I'm wearing a mask, does it protect me? How much does it change the transmission?
Sure. My colleague Don Milton at the University of Maryland is preeminent aerobiologist. Masks work. Right? It turns out that obviously the K99 would be that, and some respirator would be the gold standard, but a well-fitting cloth mask can also be effective. So I know that this has kind of gone through different periods. I think at this stage you'll notice, obviously we are not wearing a mask right now. In certain contexts I will, and I did for a very long period. For individuals who feel that they are vulnerable, or certainly if they are worried that they might be infectious, whether because they have a test and they have to travel and it was positive, or they're in a context where they're going to a high-risk population, whether you're visiting a relative in an enclosed space and they're vulnerable, or in a medical facility, these are all good reasons to use masks. I can't give you the exact numbers with respect to reduction in risk, but they work both when you wear them to reduce outflow, but also certainly to protect you even when others are not wearing them. And wearing them indoors, obviously, is where we think most of the transmission is happening.
I think
the vast majority.
I think the first interview I gave over the pandemic asked the same question, and views have evolved again in what you were saying, Patty. But it was well established long before the pandemic that masks were pretty effective at preventing transmission from people who were wearing them. As you know, to prevent infection, it depends on somewhat the mask and how well fitting it is,
And how you wear it.
and how you wear it.
Yeah,
Yes,
fine.
yeah. But you sometimes see people like
Yes,
with masks
that's fine.
kind of dangling around their chins
Right.
and like,
And that doesn't
or
work.
on their heads,
Right.
like a headgear, and then
They're amused about that.
yeah, the emergency room doctors or the doctors in general just start saying, oh, but you have to wear it correctly. And then you get into this kind of mask shaming. There is actually there was a study which suggested,
Yeah, they're looking at us now.
they're looking at us
Bill.
go. There's a study that suggested that population mask use with education how to wear them reduces transmission by maybe about 20%. And that's, I'll say, that's not bad. There's no one simple trick discovered by a mom in Somerville that's going to fix this pandemic for good and 100% effective. That's not the way it works. If you combine interventions, then you can manage to get something that's useful. And remember what I said about cutting off 50% of infections if the R number is 2 is enough to control it. Think about it. 20% is a fair old fraction of 50%. So
And that's usually what we're doing with these Swiss cheese-like ideas. But speaking of cheese,
there's a reception.
I think you have reception.
What an excellent segue. So please do join us all in the library near the entrance of the Science Center. And while you will be eager to come up and speak to the speakers right away to talk about all these interesting things, please meet them in the library, give them a chance to get over there too. And let's thank them one last time.